All right, welcome. Today, we're going to fire up the engine of the mind. We're going to strip down the core principles of mental health nursing, transforming them into a high-yield blueprint you can use to navigate the incredibly complex inner workings of the human psyche. Let's get into it. So let's just dive right into a scenario, shall we? Every clinical journey starts with a single moment. You walk into a room. Your new patient is withdrawn, tearful. The diagnostic engine is cold. So where do you even begin? Your assessments, believe it or not, starts right now. And that brings us to Section 1, the clinical encounter. Look, before we can even think about fixing the machine, we've got to understand how it's running, or not running. This first part is all about assessment, about calibrating our own tools to map the patient's internal world. Which brings us to a foundational tool, the Mental Status Exam, or MSE. Now here is the absolute key, and I really want you to hear this. This is not a checklist. It's a systematic observation that begins the second you lay eyes on the patient. The whole goal is to build rapport, not to conduct some kind of cold interrogation. This blueprint here, it breaks the MSE down into 5 pretty manageable steps. Just think of it like you're doing a systems check on a complex machine. You start with the most obvious, external data, appearance, behavior, speech, before you move deeper into the internal machinery of mood, affects, and cognition. It's just a logical flow, from the outside in. Okay, on to Section 2, decoding mood and mind. So, with our initial observations complete, we can start to assemble the pieces of the puzzle. We're looking for patterns in that schematic, trying to diagnose the specific malfunction. And that leads us to major depressive disorder, something you will absolutely see in your practice. The key diagnostic years here are duration and impairment. The symptoms have to last at least 2 weeks, and, this is crucial, they have to be severe enough to actually disrupt the person's life. That's really what separates a clinical diagnosis from just, feeling sad for a bit. Now, how do you remember all those core symptoms? You use this brilliant mnemonic SIG-E-CAPS. Seriously, from sleep changes all the way to suicidal thoughts, this is one of the most powerful, high-yield tools you can possibly commit to memory. It gives you this systematic way to assess for depression right on the fly. Being able to tell the difference between grief and depression, that's a really critical skill. And what I think is so illuminating about this comparison is the contrast. You see, with grief, mood can come and go in waves, right? But with major depression, it's more like a persistent, heavy, suffocating fog. Okay, let's shift gears for a second and look at personality disorders. The one word on this slide you really have to latch onto is enduring. See, while depression can be an episode, these are rigid, long-term patterns. It's almost like they're part of the core programming that has shaped how that person sees the world since they were a teenager. And a great way to simplify this pretty complex topic is by organizing these disorders into 3 clusters, A, B, and C. This framework just helps you quickly recognize the dominant behavioral traits, whether it's the suspicion you see in Cluster A, the instability of Cluster B, or the fearfulness of Cluster C. And that brings us to Section 3, the intervention toolkit. We've assessed the machine, we've read the schematics, so now what? Well, now it's time to engineer a response. What tools do we actually have in our toolkit to make repairs? Our number 1 primary tool is therapeutic communication. And let's be super clear about this. This is so much more than just being nice. It is the skillful, deliberate use of techniques like reflection, clarification, and even silence to engineer a space where the patient feels safe enough to be vulnerable. Recognizing the difference between these 2 communication circuits, it's vital. For example, asking why over and over can feel like an accusation, and it just shuts a patient down. But reflecting their own words back to them, that shows you are truly listening, that you're trying to understand. It's a game changer. So when we talk about major interventions, they mostly fall into 2 big categories. But what's fascinating is that they both target the exact same place, the brain's complex circuitry. We can either use pharmacology, medications, or we can use direct brain stimulation. The most common pharmacological tools you'll see are the SSRIs, and their mechanism is actually pretty elegant. Think of it like you're partially blocking a drain. They basically prevent serotonin from being reabsorbed too quickly, which leaves more of it hanging around in the synapse to help regulate mood. Now, TMS, this represents a totally different approach. It uses the principles of electromagnetism to directly influence and kind of retune the specific brain regions that are affected by depression. And it does all of this without the need for any systemic medication. Pretty incredible stuff.
Okay, Section 4, Pharmacology's Double Edge. These tools are powerful, no doubt, but every powerful machine has its hazards. Understanding the risks that come with these medications is every bit as important as knowing their benefits.
And this is a crucial safety point that you must never, ever forget. As a patient's energy and motivation start to come back, and this often happens before their mood fully lifts, they might tragically gain the physical capacity to act on suicidal thoughts they've been having.
Antipsychotics, they carry the risk of something called extrapyramidal symptoms, or EPS. And these are serious, sometimes even permanent movement disorders. Your job is to spot them early, whether it's the intense, can't-sit-still restlessness of akathisia or the painful muscle spasms of acute dystonia, so they can be treated right away.
You're going to hear this a lot from patients. They often assume that because something is natural, it must be safe. But St. John's wort is the perfect example of why that thinking is so dangerous. Its interactions, especially if it's mixed with prescribed antidepressants, can lead to a life-threatening condition called serotonin syndrome. And for our final section, the professional's compass. You know, the best mechanics know more than just their tools. They operate with a code. And for us, that means understanding the ethics that have to guide every single clinical decision we make. These 6 principles, they are your moral compass, from respecting a patient's autonomy to the absolute duty to do no harm or non-maleficence. They provide the framework for every decision you have to make. And believe me, in the gray areas of mental health, these principles are what will keep your practice grounded. And finally, we have to talk about compassion fatigue. This is a very, very real occupational hazard. Constantly working with this kind of machinery, with human suffering, well, it takes a toll on the mechanic. If you don't actively maintain your own well-being, you absolutely risk burnout. And that leaves us with maybe the most important question of all. This is the final crucial takeaway. Caring for yourself isn't selfish. It is a professional necessity. It is the only way you are going to keep your own engine running for a long, sustainable, and compassionate career.